Oh my gosh. All right. It's show 2. We're back.
What's
Just these out a little bit more than that. But anyway, we are back. We were super excited. The food was gone before we acquired it. So, you know, a little dicey over here.
We're in even worse moods than before.
Like in the best kind of way. So we're back for show 2 at HIMSS. We are starting out with Dimy from Adino, who we met last night. And he's going to tell us about like some huge problem. But first, he's going to introduce himself to our loyal fans. All of you are here, we know. And tell us about this big problem.
Awesome. Hey, everybody. Dimy Jeannot here. And from a problem set, I've just found that we've been talking about interoperability for 40 years. I'm 43, but so think about 3 years. I was probably playing with the Tonka truck, and we're still talking about it. And really, the reality is that I feel like we're on a treadmill. We do a lot of work. I see a lot of great intentions, a lot of people doing fantastic work. However, it just feels like we're not actually moving. And part of the issue is because, to me, there's a lower level issue, and there's a problem around communication between healthcare organizations. So before you can be interoperable, you have to first communicate. So that's what I'd like to talk about some, and pretty excited. Thank you for having me on the show.
Well, we were working at our many technical difficulties. You were listing, so you said you're 43, but you listed like a shit ton of work experience.
Yeah.
Like, how did this work experience lead you to this problem?
So I spent a lot of time doing some work first at the FDA, then Sharecare, I think Pfizer, Mayo Clinic, Syncora, and a lot of my work just sits behind the scenes. So no one really knows who I am, but the people who know do know who I am. And I just kept seeing this problem over and over again. Like, it seems as if the problem is a interoperability issue. It seems as if it's an administrative burden issue. It seems as if it's these higher order problems, but every time it boils down to a communication problem. And that's why in the US, 75% of all inter-organization, healthcare organization communication still happens over fax. But you think, is it because the providers or the players are just old school? And that's not the case. It's just it's just so asymmetric in healthcare that they're really told they have 3 ways to do it. Deliver it, like hand deliver it, the paper, VPN it, which is very costly to do. And it takes maybe 6 months for multiple IT teams to work through, and it's brittle, and you have to create hundreds of them, or you fax it. And everyone's used to fax, it's safe. But what it does is it creates higher order problems. And so, but if we solve the lower level one, we'll be able to break it in. I do believe why it's
legal fiction. Fax is not safe. It's just
accepted. That's exactly right.
It's just believed. It's just accepted to be, or you think you're not going to get in trouble if you.
That's right, and you usually
it's not
don't.
Actually safe.
It's actually less secure. That's right. That's right. But to do a VPN, you need a BAA. You need this 100-page document you have to sign. There's a lot of hoops. You have to jump through.
You're talking about like really like the floor of interoperability. Like what? Yeah. So how are you solving this problem?
So how we're thinking about it is, so imagine you as an organization, you don't have to install a VPN or manage one. Your IT team doesn't have to manage one at all.
Dimmy's talking to our live audience here.
I have a live audience.
We have a live audience.
Super cool. And so think one install, 0 touch by the IT group, and you have a VPN that connects. It's a mesh network, a mesh overlay network, and it just connects automatically. And so you don't have to manage it.
Right on. Very cool. Okay, so like, how'd you get it started?
So I left doing some of that work, and I said to myself, I'm going to solve this problem once and for all. Because every time, no matter who I work with, I come back to the same issue. And we're solving weird problems, but same problem. So I said, I'm going to take a year, and I got a little bit of funding, and I took that year, and I solved the problem. And so now we just landed our first customer. We have 16 hospitals, and we're proving it out. And then from there, we'll commercialize.
So can you say what the actual use cases for those hospitals, like what are you enabling for them that they couldn't do before?
So on the surface right now, we're enabling something simple, because no one wants to pay for the pipes. And that's the issue.
That's true.
Right? So if I go sell, if I go sell to someone, hey, you need fiber optic cables, like for what? Right? But if I sell, hey, you can make a FaceTime call to your son, over the Atlantic, they're like, sure. And so right now we're selling something higher order, but it's only because no one will pay us for the bottom piece. But we just need to prove the bottom that it works, and then we'll get some funding, some significant funding to
So
truly.
what is that use case? Can you tell us what
So
you're selling?
For the use case right now, we call it a summit page. So all it does, it takes a fax in. Let's say if I'm a provider, an oncologist as an example, and a document comes in, it's like 100 pages. And I only have 10 minutes with this patient.
Sure.
I don't have time to read this. And oftentimes what
All
the
the
doctor
copy
just
pasted
does
pages.
is just order new labs again.
Yep.
Because they're not looking through it.
Yep.
So we take the facts, summarize it, create like a quick executive summary, and we create indexes. So we'll tell you, hey, diagnostics are on page 57. We'll tell you that the CT scan is on page 8. And that's the simple use case for us.
Wow.
But it allows us to get in. And now we have a VPN connection that it's just super easy. And then from there, we move to labs. And so now that company can now send a lab to a radiology company, but they send a digital version.
So what you're saying is like they send that fax and you connect.
Yep.
And then suddenly by doing that, you've now enabled the digital connection.
Correct.
Cool.
So
That's great.
they'll get a digital copy directly into their EMRs, but they also get the fax. Some of the doctors, they've been using the fax for 30 years and they're so used to having it. So we don't want to take it away. We'll let them elect whether or not they want it or not.
Okay.
So that's the idea at this time.
You know, we just had a guest on in our first show, Dr. Hamid Husseini, who is from rural Alabama. I forget the name of his hospital. He's going to be mad at me. But he was saying, this rural health transformation program, and he's like, oh, AI, people are flinging around all kinds of tech. He's like, my hospital hasn't had, my EHR is no longer
We don't have any EHRs.
It hasn't been supported for 15 years.
Yeah.
And we fax everything. We do, it's like his summary report is an Excel sheet that someone types in for him.
Yes.
So, and I think, I mean, that's super interesting with what you're talking about, right? You're like, hey, you see the same problem.
Yes.
But still getting faxes. We talk about faxes all the freaking time, blah, blah, blah. But like, is it, how prevalent is the problem? I assume you're working in Atlanta. That's where you're.
Yes, I am working in.
Yeah. I mean, I know Atlanta hospitals too, or whatever. But like, where else do you see this problem? You'd be working with these other organizations that are national.
They're all throughout. So we're working with the company. So I'm in Atlanta, but we're working with a company out of San Diego.
Okay, cool.
And it's a federally qualified health center. And so you see this problem literally everywhere. And my concern for the healthcare industry, why now? It's because AI really can help, but physics will always set in. And all it takes is for one provider to get sued and lose their ability to practice. Like they can't put their child in private school anymore, for people just to revert right back to the old way.
Yeah.
And so to me, until we solve those low level pipes and make it so that we don't inadvertently push people back to fax, we'll miss the opportunity of AI. And so that's what I don't want.
Yeah.
And why I believe, and even if you look at what TEFCA is doing, I'm really glad because some of the policymakers, they're pushing this. And so think of us as an on-ramp to TEFCA. So whereas, what I've seen, it's not a technology issue, it's more of a fragmentation. To your point of the Alabama issue, there's so much fragmentation. The ability to on-ramp onto TEFCA, you have to, take 6 months to go through legal, 12 months for an IT project. Imagine doing that in rural Alabama where I don't have a budget, my IT team is really small. We become the on-ramp where it's zero touch, easy install, and now you can connect to TEFCA.
Because you're taking the fax, you're making it useful for the provider, and you're also sending it into cyberspace.
That's right.
Okay.
That's
Cool.
So that's the idea. And
yeah. So in some ways, your goal is to put yourself out of business.
Well, no. And I'll tell you why. So if you we can think of it as out of business only because you're not trying to get rid of, I'll say it this way. You can get rid of the fax, but it's only there. It's like a Band-Aid. We're trying to get rid of that Band-Aid so that you can do higher order things. Like, for example, yesterday I was in a talk and someone was representing pharmacies and they were like, we don't get any of this data.
Yeah.
So so yes, you get a prescription over the SureScripts network, but you don't get the claim. You don't get like prior auth information. There are no pipes to do it.
Yeah.
And so that's where so much wastage comes in. So to me, it's not so much getting us out of business, but more reducing the amount of administrative waste there is in the system. And
Yeah.
and I do believe right now, like even our costs, our health insurance just skyrocketed.
Mhm.
And for everyone, I'm sure all across America. And it's going to reach a point where folks are going to start rebelling soon, or it's
Yeah.
going to be an uprising. So something has to change.
Yeah, we're just not getting health insurance.
Well, but that's so dangerous because what if
Yeah.
something goes wrong? And
Yeah.
So-
Yeah. Yeah.
Well, who earns less money if you're successful?
that's a great question. So one of the things that we focus heavy on is not disintermediating folks.
Hmm.
So oftentimes, so that's one thing that I've learned having worked with some of these bigger companies. They'll find their way to shut you down
Mhm.
without ever you knowing who they are if
We
you
know.
try to
We know who they
disintermediate them. That's right. So our strategy is
We heard about them.
We heard them. We heard 'em.
oh yeah. Our strategy is we don't sit in between the transaction on purpose. So let's say that if company A wants to talk to company B, we're not a relay. They don't send it first to us and then we send it to company B.
Hmm.
That's what, if you think of HIEs work in that way,
Yeah.
where you send the data to the HIE sends it to the other party. We work in a way where it's peer-to-peer, where if, let's say, a lab wants to talk to a provider, we facilitate the transaction, but the lab and the provider talk directly.
Hmm.
So we facilitate a VPN pipe peer-to-peer, and we can't see the data at all.
Huh.
And that's where I believe is critical, because if you try to sit in the middle, you'll become too big, and people will find a way to shut you down. But by removing this, yes, pipes and governance, trust. So now I can credential party A to say who is party A. I can credential party B. Who is party B? Do they want to still communicate? And if so, we let the transaction through. If not, we can cut it on either side. But we don't see what's inside the pipes.
We'll see if that holds up to an information blocking claim.
That is interesting to think about.
Yeah. Well, I'm sure that it is a legal, it's an area of legal intrigue to figure out who is actually a network. What does a network mean?
Yes.
What is it creating a network mean? You know,
Yes.
if you're just enabling
What does that mean?
peer-to-peer. Yes, I don't know. We'll see.
That's
But
right.
it's an area.
And those are some of the
We
policy
don't have
issues.
answers yet.
That's right.
Yeah.
That we'll have to work through.
Exactly.
We'll have to work through.
Yeah.
Exactly.
Very cool. Yeah.
Nice.
So what's next? So you're proving this out.
Yep.
You're gonna get some money,
Yes.
and then like what do you think is gonna happen in like 2 years?
So at this point, we plan on skyrocketing pretty fast. So I believe in this whole model of slow, smooth is fast, in the whole Navy SEAL world of shooting. But I believe it applies here.
Yeah.
And because you're not moving, this is not a technical problem. You're moving a behavior. You're moving.
Right.
You're thinking about psychology, and so you have to position it where a clinician can simply do something they're used to, like print, and we intercept the print, and we facilitate a digital transaction.
Yeah.
And so slow, smooth is fast, but we do plan on moving pretty darn
that.
fast.
We talk a lot about friction in healthcare and how things might all be set up, but it's like still humans being like,
Mhm.
I'll have to type like 4 more things there, so do that.
That's right.
It's pretty cool. I'm glad that you're addressing that.
Yeah.
It's something
And I generally think like focusing on the infrastructure and the pipes is a really important issue.
Mhm.
I agree with you. It's just not there.
Yeah.
Like it's just not. And you're right. You're absolutely right that nobody wants to pay for it.
No,
Yeah.
it's okay.
That is a true statement. They
facilitating like this digital stuff that is a real thing. That's very cool.
That's it.
Any final words for
Programs.
truly millions of loyal fans?
Yeah.
So if anyone wants to just stop hearing about interoperability as a buzzword, come visit us at adino.com and just come on a mission with us, because we're not here to be the center of the universe, because we don't believe that.
That's us.
Okay, yes, that's right. That one company will be able to change everything, but just to do our part and reduce the cost and improve care for everyone.
Love it.
Awesome.
Well, thanks, dude.
Thank you so
Yeah,
much.
thanks.
Ladies,
We're gonna call you and see what's going on.
That's right. Awesome. Okay, we are still live. We're doing a live change.
Live
change
switch here.
Live switcher.
Great. Yeah.
Live switcher.
Awesome.
Hold on a second.
Oh,
Danger
Melissa just
zone.
almost fell out the door. All right, now we've got cakes from Clover. Oh my goodness.
Hey.
Hey, how are you doing? Sorry, there's so many
guys.
here. They just, I mean, you know, it may or may not work.
Whatever.
It's
It's fine.
guys.
Nice to meet
you.
Thank you.
Clover, what is even going on?
Great. So why don't I just give a little bit
Yeah.
of who I am and why I'm here today. So I'm Katie Whalen. I'm with Fiserv, which is a Fortune 200 payments company. Not Pfizer, but Fiserv, financial services. Very different.
We're in Atlanta.
We're in Atlanta, but we're based out of New York too. Our headquarters is in New York, but we do have a big office in Atlanta. And Clover is our small business solution that helps businesses run their businesses, as well as kind of help them support payments.
So the payments, because
It's payments. It's all
like
payments.
this is wait,
You see the cap.
It's a consumer. I have interact. Okay, great.
Yeah, and it's like there's a
Got
screen, there are kiosks.
Nice.
We deliver to like over a million customers in the United
Yep.
States. We've shipped over kind of 4 million devices since we launched it about 10 years ago.
Nice.
And historically, we've largely served the restaurant, retail, and services verticals.
Sure.
And as of tomorrow, we will officially be in market, which is super.
Okay. This is a very important announcement happening on the Health Tech Talk Show.
It's real.
Let's do it.
So what's going to happen?
Well, we're officially letting our sales team actually start selling the product.
Nice.
Pilot.
Nice.
We've piloted with about 30 merchants so far that are really small providers across all the subverticals in healthcare. So that's dentists, chiropractors, home care services providers, med spas, really kind of anywhere where you would take a credit card payment for a patient, and then also have some sort of insurance claim process that would need to be supported in line with the actual payment the patient is responsible for.
Yeah.
Okay.
And what we've done here is we partnered with a great partner of ours, Rectangle Health, to make sure that we're HIPAA compliant in the solution that we're providing, whereby we're taking the best of the capabilities we have for all other verticals, for restaurants, for the devices, the screen, real estate,
Right.
the software, the value-added services like working capital, employee management, inventory management, and partnering with Rectangle Software Solution, which is already embedded in the healthcare industry, to enable it to link back into EHR and patient management software systems to have real-time data exchange back and assigned back to the patient for the payments that they're making. And then also what we're going to be kind of launching later this year is also kind of payer synchronization as well, because in the healthcare industry, you get 20% of the $5 trillion that run through the industry, 20% is paid by a patient, 80% is paid by a payer or kind of insurance provider. And we want to start closing the loop. And we believe the payments capability can help start closing that loop.
Well, that's what I was going to say, because like the experience right now, when you go to a doctor's office, you have that appointment, right? Whatever. Usually they do like some kind of previously did kind of a benefits check, eligibility check. And then they know from that and your information, like what your copay is or what your co-insurance is, that they can collect up front. They do that. And then maybe at some point in the future, you find out about the rest of the money that you owe. And maybe and there's also a collections issue, obviously many collections issues as well for practices. But like, are you guys looking at like shortening that gap between that real-time benefit check, what a patient has to pay, and then also like the rest of the payment?
That's exactly right. That's exactly right. And that's
a good idea.
I support that. We're just launching tomorrow, so we've got like a
you're
plan. You got
Which is awesome.
Yeah.
But we firmly believe, as we started digging into kind of like what a solution could look like, how we can move just beyond the payment,
Right.
that everything really starts from the actual swipe or kind of the payment initiation with the patient and the dissemination of information.
Right.
And oftentimes the point you just made about that kind of EOB or explanation of benefits.
Someday I'll get back to you.
And it's oftentimes a guesstimate.
Right.
And therefore,
Totally.
when it's a guesstimate, it creates then kind of inefficiency in the downstream flow, both the payment as well as the data, that we can help to kind of close if we have real-time adjudication using the screen real estate that we have from the device itself.
Yeah.
And so we're really excited about this. And I think largely as we were looking at the space, we really kind of came to the conclusion that healthcare has been largely underserved by the payments industry, and that we have a kind of right to play here and to really help close that loop that reduces that friction. And your point about collections, because of those guesstimates, about 40 to 50% of patient payments that go into collections oftentimes get just written off. So and that's just like a massive amount of inefficiency, headache for providers, especially small providers that might have an office admin that's the one doing all those claims management or collection management. So we believe that there's opportunity for us to really kind of start closing that loop and start reducing some of that friction, especially for providers that are probably the most vulnerable and need most help.
So 40% get written off.
40%.
Dang.
But
40% of
you need
payments that are in collections.
But you could, because basically like your best opportunity to be paid for whatever service you're offering is like at the point that you deliver.
Yeah, exactly.
Like, otherwise you go into a world of like, maybe.
Yeah. So you're saying like now when I go to the doctor and they say, yeah, we'll just charge you like $30 because like we don't know and we'll send you a bill. Like They would just be like, actually, you owe us $475 right now.
And so wonderful is if you walk into your doctor's office today, what you'll oftentimes see is kind of what we call in the industry is a like dumb brick, if you will, or just like a dumb terminal that just collects payments.
Yeah.
There's so much information. It's the
Yeah,
credit card.
it's just a credit card reader. And what we have with Clover is if you've experienced this in your local cafe or restaurant, is there's screen real estate and software behind the device that we can also develop specific software for healthcare, the industry. And what's exciting is on our roadmap for this year is having multi-tender options, which means that you go in and you can then select what type of combination of payments you want to make for your $475 payment.
Your HSA card.
And say, okay, we want to identify you with maybe your last four, or maybe there's some biometric identification from the device, and I can pull back your HSA balance and say, oh, I want to maybe pay only like 200 of my $500 of my balance. I'm going to then supplement it with financing, or I'm going to then use either a credit card or pay my bank. And then I have more options to kind of select from that is presented to me as a patient that I can then plan for, how I'm going to pay for my service with, more certainty and transparency.
We're talking about like healthcare payments, which historically has been boring. This might be like the most thing we've talked about today. But everybody's like, we could do this. We could do the AI.
It's also truly like the consumerism piece where you're saying like, let me bring some kind of like modern payment technology that's in use in other parts of the industry.
That everybody says
like, we'll never improve on this. It's going to be bad.
I know. We're just always going to, like, maybe it's always going to letter saying you have to send a check back in the mail or something.
Yeah.
It's like, because we've been talking a lot about how like consumerism will drive change in healthcare, and like the payments, like that's actually like
that one feels like a place where you could see improvement.
Yeah. You're doing like the benefits check on the back end or the front end. I don't even freaking know, but whatever.
Front end and the back end.
Yeah, and then we've got all these complicated things like HSAs versus like what's your plan going to pay, and then like cash
financing options.
And you're saying like just right there, like the patient can make
why can't you just do it?
I mean,
like,
you do it on Amazon.com. Why can't you do it at a doctor's office?
Yeah, I agree.
The cool thing is like you're doing this. I mean, I assume you roll it out for other provider sites, but it's just little ones right now.
I mean, it's actually really been interesting as we've been, it's really small providers, but because of the nature of the healthcare industry with the roll-ups that have occurred with either PE or kind of like bigger, kind of more corporate roll-ups. Oftentimes we're also finding is we could serve hundreds of locations from the operational nature of those roll-ups or PE shops that really drive efficiency through their kind of roll-up nature. And so we're actually finding going a little bit more upmarket than we expected.
I would imagine that PE roll-ups would be like, yes, we would like to do that.
Yes,
please.
It was, paint the vision here of like where I would eventually love to get to is, we talked about the doctor's office. So I live in New York City. I go to Cornell Wow, which is like a very well-funded, a network. And I went to my GP office. This is last July. And you walk into the doctor's office and there's a piece of paper that's been printed on 8.5 by 11 that says sign in at kiosk. And you walk in, and to the left, there's a iPad that's been affixed to an IV like roller. It's like a pin pad here with like a homegrown, sign up thing. And then that pin pad is different from the pin pad at the checkout that then has a signature pad.
Sure.
And when you think about that, why is that different from a restaurant where all the operations should be talking to one another, and just linked together in terms of the workflows, and they're all so fragmented and disconnected that we have already solved for in other verticals that we should be able to bring to the healthcare space.
Yeah.
So that's kind of our vision of like, how do we reduce the friction and the administrative costs for providers, like we've already done in other verticals? How do we improve the patient experience, not dissimilar to a consumer? And how do we then make sure that the reconciliation and the cash flow management is done on the back end, because we operate in the payments and financial.
So what was beyond like, there's obviously a need here, imagine there was some hesitation to entering healthcare has a lot more regulatory burden, even than like other parts of payments and the financial system. Like what was that decision? Like, is that how you
were just like, we're ready?
Like, how did you?
Let's go.
Yeah.
Before we're doing that, what's your background?
Yeah.
Are you a healthcare person?
No, I'm not a healthcare person. I'm a payments person. So I've been in the payments industry for over 15 years, with American Express and Citi, and then with First Data and Fiserv. I got a little bit deeper into the healthcare space. I used to run what we called our issuer processing business, where card issuers outsource their processing. And we're a mass scaled processor, and we ended up winning a lot of business for HSA, FSA benefit administrators.
Yeah.
Over the course of like the last few years, and to the point where we really got the majority of the industry in terms of cards in force. So we got to know the HSA balance management and adjudication for RX payments really well. And then I moved over to the merchant space, and we partner very closely with bank partners for distribution of our payment services. And when I started in merchant, I talked to our bank partners and said, well, what are we missing? And the number one thing they said, you don't have a healthcare solution. So, and one of the biggest barriers was HIPAA compliance, and our environment wasn't HIPAA compliant. So we ended up partnering with Rectangle Health as a partner. Who did have a HIPAA compliant software solution that we white labeled, and then connected it with our Clover devices and our Clover gateway, which is where we process the payments, and brought it together as a single solution in a bundled rate that we're now providing to providers. That we're now integrating our best solutions into the software package that includes working capital, inventory management, employee management, payroll. So all the things we've already been doing, we're bringing it to kind of providers in a HIPAA compliant way. So we're super excited about it.
Unlike the non-successful.
About like, there's not like partnerships in healthcare, and like not to get.
What do you mean
like
by it?
Like, oh, you're just like hanging out, like your friends, like you host a happy hour together. It's like cool. Like
Sounds like you guys
it's like I want to be real happening. Awesome. So how long? Like, what was the start to finish on this? Like, you're launching today-ish.
We're launching. It is turning on for our sales team tomorrow. Tomorrow morning.
Like,
How
long did it take you to get here?
We were in the room with Rectangle end of January last year. We signed the contract in July and started integration in August.
That's pretty fast.
So it was pretty fast. So we actually moved pretty quickly when it comes to some of the small business capabilities we have. And Rectangle's been such a great partner, and we've been able to get it market pretty quickly. So we'll have more iterations as we move forward. We're making some tweaks and some early feedback from pilots, but we're really excited about it.
That's awesome.
Yeah.
And then so you've been testing it a little bit in the market with obviously, Like, what's some of the early feedback we've gotten?
Just some. They've been really excited about the real-time posting of the payment from the swipe all the way to the kind of patient management software and EHR systems. So there's an overnight batch that occurs for that, so you don't actually see it.
Nothing is actually real time.
Actually have an ability to flow that all the way through. I'm excited. The other thing is we have, it sounds really boring, but it's called a card vault, where you can actually do stored cards on file for patients, so they don't have to kind of pull out their card.
That is actually my favorite thing. It's not so basic where you're just like, they're like, should we use the card and file? I'm like, yeah.
They're like,
yep.
There's card account updater, and then the most important one, which we're really thrilled about, is in our partnership with Rectangle, they have a claims adjudication or reconciliation process. So when they actually get the email or pack down or file from a payer, oftentimes that the admin needs to then unpack that file and manually tag it to a patient. That is done automatically from a reconciliation standpoint, so it reduces the burden on the admin to like actually.
Yeah, if I were running if I was like the solo practice manager somewhere, I'd be like, absolutely. But I mean, there's more people, even in a bigger system, you have a bunch of people too. But as a solo or a small practice, this would be like a no-brainer to have something that can help you with this for sure.
Do you have any competitors doing this?
No one's doing it.
Oh my God, I freaking love it.
Like it's kind of it's as
is that possible?
Because it's just
not like hard.
It's hard, and I think it's the HIPAA compliant component of it. And is prevented really the payments industry from really stepping in effectively. Like Visa and MasterCard really operate effectively in the healthcare space, but they do it at a network level. But no one's really solving for like the local doctor's office or family doctor's office.
Or just it sounds like also like the innovation aspect of it, right? Or like innovation in healthcare, which is maybe like something that's been like table stakes elsewhere, but there's nobody's looking at like, how can I make this to be truly a better experience? One tip that you probably don't want to hear is that veterinary.
No,
if they haven't already gotten you like angry, like we need this now, like that's a perfect place for that.
Yes.
Like
Lisa,
veterinary medicine, they're like
yeah.
they will love
Yeah.
this.
And it's one of the reasons why we're like so excited to be here at
Yeah.
HIMSS. We typically have historically not had a presence here, but we're a sponsor for Emerge, and we're so excited to sponsor the track because it brings like investors and innovators
Yeah.
and entrepreneurs together.
Nice.
And at the end of the day, I know there's a lot of talk about AI, but at the end of the day, it's really about solving like very real problems and cutting time out of the system. And there are some ways we can do this really quickly, as we kind of demonstrated, that I think makes demonstrable impact on those that need it most in the system.
Awesome.
Love
Well,
it.
Great.
Well, what like
We love it.
last thing do you want to tell our loyal fans? It could be anything, you know? I don't even know.
Well, just check it out. We're officially launching tomorrow. It's Clover Practice Pay. You can Google it. And if you have feedback, we're all open. My name is Katie Whalen. You can find me on LinkedIn if you have any kind of anyone wants to reach out. But just I really appreciate you guys having us here.
Thanks so much.
Thanks, Jared. Lots of great feedback.
I'm back again here.
Yes, please. Yes. Oh my gosh.
Very good. Thanks, Dimy. Thank you.
Yeah.
All right. Trade off though. We're still live.
Yeah, we're still live.
We're live.
Still
Still
live.
live.
We're just like getting
There you go.
clowns.
We just keep it rolling. We just keep it rolling.
Yeah,
Thank you. Thanks everybody. All
Oh my
right.
goodness.
Hello.
What, are you
Still
intimidated?
live.
No,
Oh my god.
Are you intimidated?
Dave? Hey.
I'm sleep deprived, so
Oh, so we
yeah. Nice to meet you both.
like a little beat up.
Yeah.
What happened last night?
A lot beat up.
I don't know. Dave, tell our loyal fans all about yourself.
Hello, loyal fans. Dave Lucey, CEO of Medisolv, and excited to be here.
So I just saw in our Health Tech Taxo Gmail, which sometimes we check.
Oh, yeah.
You guys have like a big AI announcement.
We did.
Yeah,
We're
what's-
super excited. Yeah, we announced today that we acquired Lilac Software.
Cool.
So I've been working on this for a bit. Super
Yeah.
excited. And it's bringing together kind of really two strengths. So Medisolv, over 25 years, really strong in clinical quality measurement,
Okay.
quality reporting, quality analytics, and found a great complement on the payer and payvider side in Lilac.
Yeah.
So they bring all the claim measurement, and they've done it with a lot of native AI capabilities. So
Okay.
predictive analytics and some really interesting approaches to quality gaps and patient engagement.
Yeah.
So, super
So what are
excited.
you guys going to do together? Have you talked about that in the announcement? Like, what's the plan?
Yeah. What?
Can you share with us?
Yeah, so right off the bat, so we support patient reported measures and have for a while. And those requirements are kind of ratcheting up in terms of the sampling and the accuracy and the kind of follow through with the patients. So they've got a voice AI capability that's going to be able to kind of chase down those patient surveys and
Oh, right on.
take that administrative burden off the nurses so they can actually
Yeah.
pay attention to what's most important.
Yeah.
Yeah.
Do you think we should just like wipe out quality reporting? I think we should just be like, we're not doing that anymore.
I don't want to wipe it out. I want to make it so easy that you don't have to think about it,
Yeah.
right? And that you can actually trust the underlying data and trust
Right.
the information that's coming through that process
Yeah.
to use it for much more strategic purposes. Obviously, we need to kind of check all the compliance boxes. We've been doing that for over
Right.
25 years, really for all the variety of programs, all the variety of measure types. We're really trying to elevate the role of the quality leader within the health system and eliminate that administrative burden, but allow them to really use that information to drive patient safety, patient experience, financial outcomes, and really, walk around without any doubt that the underlying data is, reliable and complete.
Yeah.
Yeah. I mean, do you think that, doctors and practices and clinicians are ready for that? I think there's definitely a trust gap of like, what am I reporting to the government or the payer?
Yeah.
Right. Like, where's that,
I think that's spot on. We're trying to really unlock the lineage of the data and the evidence of where it came from
Right.
and why you should trust it and
Right.
what actually is involved in a measure. And then that you can not just believe the output, but you can trace all the way back where
Yeah.
this data originated.
Yeah. Yeah.
Spent a lot of time, a lot of investment in data mastery. And the fact that that's purpose built for the quality leader and it is
Sure.
all we do. We don't
Sure.
we don't serve any other kind of functions
Sure.
or practices.
Yeah. That makes sense. What about like, it feels to me sometimes like quality measures themselves are very much like a bit of a game of collecting the right numerators, the right denominators, the right exclusions. Like, how do we get to like a full data view? Like, right? I mean, I realize measures have definitions.
Yeah.
I'm not trying to say this isn't the case, but like, can't we look at the full universe of what actually happened versus like a little like picking these pieces out here,
Totally.
there, and the other place? You know?
Yeah, and it's a real actually it's one of the attractions to the Lilac capability, and where we're kind of like-minded is the ability to use standard measures as a jump-off point, but the ability to customize them and really kind of look forward of where particular models or particular insights are going, versus a lot of these things are locked and very retrospective. But if you can get outside just the definitions of the standard measures and make your own adjustments and own determinations of what's really important to you, you can then really dial it into quality improvement initiatives versus getting kind of locked into just reporting it for the sake of compliance and then looking at it, go, this doesn't really help us kind of move the needle on anything, any of the things that we really care about.
Right. I mean, the whole point is to drive health outcomes, right? Like
Totally.
people's sexual health.
Yeah.
Well,
Get Cat to stop eating red meat.
listen, my best friend Bobby flipped the pyramid song. Great.
Yeah.
So we were talking about like just removing the EHR and the AI taking over, and like we don't even need that anymore. Like, how, like, is that a world you think is actually going to happen?
No, I mean we really pride ourselves in pragmatism. So like we're really looking to leverage AI and probably some of the more boring and uninteresting parts of the jobs to be done. Like gathering the data and dealing with mapping and dealing with validation. So we just see it as a tool in the toolbox, but been doing this for way too long to think that there's any silver bullets or nirvana with technology. It's capability, it's enablement, and we're all for that. But it all needs to be grounded in this kind of customer obsession, really understanding the jobs to be done. The quality leaders, and that's where we're focused and trying to apply it.
Well, we talk about that a lot. Like, the best places for AI right now in healthcare, even though we're all talking about clinical AI,
right?
Like, it's really like back-end administrative processes. So what's going to be the most beneficial? Like all these.
It's like what a provider, what a clinician and doctor practice do is they have to meet these regulatory requirements to report quality measures to a payer, the government, whatever. They have to.
For example, we activated one of the largest ACOs last year, and to gather all the data from the underlying practice management systems, we needed to do over 1 million mappings to the measurements, right? So it just becomes untenable and unscalable without kind of leveraging technology.
Wow. How would that have happened before, y'all?
A lot of old-fashioned, ETL type developers do that with a lot of scripting. So that's where we see the real leverage, is to be able to do that much more rapidly with much more confidence. So when you see information that's coming out of the measure engine now, and you don't think it's right, it's not because of the data transformation or data mapping. It could be about the underlying clinical documentation of where the data was originally sourced from. Or it could actually be a measure that's just off in terms of it's legitimate and we need to do something about it
you need to be able to understand what that signel is, right? You need to know, is it a data problem? Is it that our actual results are very bad and these patients are very, their HbA1cs are way out of whack or whatever. You need to know that. And I'm sure it's always a data dumpster dive to try and find
scavenger hunt.
Scavenger hunt, that's better than dumpster.
But that's our mission, is to make these things rock solid, bulletproof, that you can rely on them for a whole bunch of functions and insights, and to just make it much more actionable, much more near real time, and that the compliance part of it just kind of comes along for the ride.
Makes sense. So one of the questions we ask a lot as well, with all this, you're automating, you're making things easier. Say you're super successful, which you're sure you will be. Who makes less money?
It's a great question. With value-based care, and we're deployed in 1,700 facilities, so we're in a quarter of the hospitals, right? So our kind of anchor point is, really helping with the financial outcomes of the health systems. But more often, like this shared risk and being a pay buyer, the lines between, the payer and provider markets are definitely blurring. And I think it's convergence is happening of, hey, we both need to win.
Yeah.
And that's kind of where we want to play. And historically, it's been about penalty avoidance, and that's where we've helped most. But more and more often now, these measures are crucial in terms of realizing upside.
Yeah.
So things like the T model, things like ASM, even brand reputation of things like Leapfrog and hospital ratings. These are all factoring their way into financial outcomes, and that's what we're really trying to be front and center.
Yeah. Another question, another hot take from you.
Yeah.
We need. So I was just reading a bunch of LinkedIn posts about the ACHE conference, and apparently the hot thing there is value-based care is dead.
Snore. We've heard that.
Yeah.
I know.
We've heard that. We've heard that a few
I
times.
know,
before, right?
but we should ask.
No.
Yeah, I mean, I'm been around long enough where with capitated arrangements, risk sharing. I don't think paying for performance should ever be dead, right? We should
Call it whatever you want.
You want the best quality
Right.
for the lowest price possible.
Yeah.
So whatever label it has, I think that just becomes kind of fodder for more people to kind of get their piece of it. But at the core of it, performance and quality outcomes are always going to matter.
Yeah.
Right.
Okay.
Yeah.
Well, tell us what are you seeing here that's awesome?
So just got here, but super excited to walk the floor.
He loves the inside of the press room.
Yeah, here we are.
The beautiful inside of the press room is really
Where? Baltimore?
Baltimore, yeah.
Oh, right on.
So been a few years. Floors are just excited to see some old friends.
It is. There are a lot of people out there, and that exhibit hall is massive.
Yeah. Wait, well, I have more questions for you.
Yeah.
If you could change one piece, the quality reporting program, what would it be?
One piece.
Actually, just abolish one part of it.
The lag, two things probably. So the lag from proposed measures to being effective right now is.
That's a great one. I agree. I concur.
And by the time they're implemented, everything's changed.
Right.
I strongly concur with that take. That is
and then, we've become, very clever of gathering data wherever it may be. Obviously, it would be in everybody's benefit if it becomes standard in terms of, moving from electronic measures to digital.
Yeah.
And there being a de facto standard that's widely adopted behind it.
Yeah. Love it.
That's
way overdue.
Yeah.
Nice. Awesome. All right. Any final words for our surely millions of loyal fans and all of our many
mantra is quality solves everything.
Quality solves everything.
Right. So it's easy to say, hard to do. And to put an arm around a quality leader's shoulder, that's a very thankless job. And the more that we can do in order to kind of elevate their role, elevate their influence and persuasion throughout the organization because of the amount of trusted data and insights that they're walking around in their back pocket from us.
Yeah.
We really think that's achievable of solving everything.
Love it.
Awesome.
Yeah.
Well, thank you so much.
Thanks for taking the
Okay, I think we're gonna call it for today. I'm gonna end our little recording here. Bye, everyone. Bye.